All right, we're going to go on now to what's next. Is my turn now?
Yeah, this
Okay.
is COPS.
All right. So we are doing the next society is now. Did you want to show that? You'll show that slide later, right? So we have the next society is the CAPS meeting, and CAPS actually won last year. So they're the what do you call it? They're the reigning champion. So they have to see if they can be dethroned. And by the way, they have their annual CAPS meeting in Ontario, September 28th to the 30th, and you can scan the QR code there to learn more about it. So these are the three participants of the finalists of the best papers from last year's Canadian Association of Pediatric Surgery meeting. First, we have Dr. Joshua Ramgist, who is a fellow of general surgery at Hospital for Sick Children in Toronto. He has developed a 5-point enhanced recovery protocol for pectus excavatum. It's a retrospective study that aimed to compare the outcomes in patients that underwent a minimally invasive pectus excavatum repair before and after implementation of ERAS. The next one is Dr. Christina Theodorou, who is a resident at UC Davis Medical Center, and hers is evaluation of a novel biodegradable polyurethane patch for repair of diaphragmatic hernia in a rat model. This was a pilot study, a preclinical study that evaluates the novel polyurethane patch for the repair of CDH in comparison with other known patches. And finally, Wendy Song, who is a medical student at University of British Columbia, presenting a comparison of operative and anesthetic techniques for inguinal hernia repair in infants. This is a retrospective cohort study between 2016 and 2020, where surgeons did open or laparoscopic procedures and general or caudal anesthesia for inguinal hernia repair, and evaluated the surgical outcomes and resource utilizations of all of those different combinations. So again, we have the ERAS, we study for pectus, we have the biodegradable polyurethane patch, and we have the different anesthetic options and the outcomes for inguinal hernia repair. So let's go to the polls.
Spend a medical minute with Kaleida Health.
Childhood obesity is very prevalent in the United States. Unfortunately, about 18% of the childhood population struggle with obesity.
One of the most important aspects of our program is that it's multidisciplinary. So in addition to having medical docs see you, you're seen by registered dietitians. We have several psychologists. So each patient, when they come in as a new appointment, can be seen by the whole team. They go to a room and then one after another, the team members go in and see the patient.
At Children's Healthy Way of Buffalo, we give an individualized treatment plan for the family. It's not just meant for the child, but the family as a whole.
Our psychologists are very important to help us with the family piece of this. And it's a family problem, a family issue. Most parents are desperate. They're frightened to death.
This Medical Minute was brought to you by Kaleida Health. We see more than patients.
All right, we're going to call it. We think we have the poll results here is evaluation of a novel biodegradable polyurethane patch for repair of diaphragmatic hernia in a rat model, a pilot study by Dr. Christina Theodorou from UC Davis. So let's go ahead and roll that video.
Thank you for the opportunity to present our pilot study on the repair of diaphragmatic hernia in a rat model using a novel biodegradable polyurethane patch. We have no conflicts of interest to declare. The optimal management of congenital diaphragmatic hernia is an area of active research. In cases of large defects, diaphragmatic replacements are used, most commonly synthetic patches, such as PTFE or Gore-Tex. However, these replacements are associated with significant morbidity, including hernia recurrence, bowel obstructions, and chest wall deformities as the child grows. The ideal diaphragm replacement would integrate with native tissue, mechanically match the function of the diaphragm, and allow for growth with the child. Our lab has collaborated with a bioengineering team in Texas who are actively investigating the use of polyurethanes, or PU, which are elastomeric polymers. In particular, biodegradable forms of PU have been used in tissue repair recently, such as vascular and muscular tissue replacement, and have high mechanical strength. We tested the PU patch in a rat model, comparing it to diaphragm repair with Gore-Tex. We hypothesized that this novel PU-based patch would be durable and would not result in recurrent herniation. Additionally, the elastic nature of the patch would allow for more diaphragmatic excursion than Gore-Tex. We created a surgical model of diaphragmatic defects in rats, creating 4 mm defects followed by immediate patch repair. Each cohort had 6 animals, as well as a sham cohort of 6 rats who underwent laparotomy without diaphragm defect creation or repair. After repair, animals were survived for 4 weeks with fluoroscopic evaluation of diaphragmatic excursion with respiration at 1 and 4 weeks post-op. At 4 weeks, they were euthanized and dissected to evaluate for hernia recurrence and adhesions to the patch. H&E staining was also performed. No recurrences were seen in either cohort. At 1 week, there was no difference in diaphragmatic excursion between sham, Gore-Tex, and PU animals. At 4 weeks, Gore-Tex had limited diaphragm rise compared to sham, but no difference was found between PU and sham. There were no differences between PU and Gore-Tex at any time point. Moving on to the histology, an inflammatory capsule was formed surrounding both patches, and there was no significant difference in the size of that inflammatory capsule between the cohorts. In conclusion, the novel PU patch was similar to Gore-Tex in its short-term durability, with no recurrences at 4 weeks. The PU patch allowed for diaphragmatic excursion that better matched the sham cohort. Both patches formed surrounding inflammatory capsules. However, further work is needed to evaluate long-term functional outcomes and to further optimize the properties of the PU patch. There are several limitations to this small pilot study. We had small numbers of animals in each cohort, thus likely underpowering us to detect significant differences. Additionally, the 4 mm defect size is small, and we are performing additional studies using larger defects. Longer-term follow-up will be important, as most recurrences occur at least a few months out from surgery, most commonly within the first 2 years. As the biodegradation rate of the PU patch can be altered, by performing serial studies over a variety of time points, we hope to match the degradation rate to the rate of tissue ingrowth with the goal of complete replacement over time with native diaphragm tissue. Thank you.
Great study. And I don't know if we are able to get the author in or not, but Tony, Alan, Cecilia, any comments?
Well, I would have loved to have asked the author what the rate of biodegradation is. It cannot be too fast, of course, because then you'll have another hernia. So,
right.
And I think what is the intrinsic strength at different time periods will be really important to understanding its use for a patch of the diaphragm.
Do you think? What is your thought on absorbable versus non-absorbable patches in general?
I think there's some evidence that the absorbable patches are not as good, and the recurrence rate is higher for diaphragmatic hernias. I personally use a Gore-Tex patch, and that stays there forever and gets embedded into the tissues because of the high incidence of biodegradable patches and the high incidence of recurrent hernias. So it's an interesting concept. There are other biodegradable resources that you can use, but I'm a little concerned about the recurrence rate.
Yeah, I agree. And I think this is true in a lot of things. Is we used to think that everything we keep swinging back and forth. We used to think everything had to be non-absorbable. Then we said, oh, we like absorbable. You may not need non-absorbable. And now we're starting to find we may use it too much in different situations. So I think it's encouraging to see the better excursion, that it may be less restrictive, but you're right, it has to at least last a durable amount of time, and unfortunately we won't know how long it lasts, to be honest.
And the other question, Todd, I would have asked is, this is a short study. Perhaps it'd be better longer to see what actually the ingrowth is and what the actual diaphragm looks like once the polyurethane has reabsorbed.
Would that satisfy you, Tony? That if you could see, let's say you can't follow them for 10 years, but you could see the ingrowth was substantial. Would that satisfy you as data to, or do you need to see the actual clinical recurrence?
I think you could probably do some testing, maybe at 6 months, a year, and sort of see what the tensile strength, the breaking strength of the diaphragmatic tissue, whatever it is, that's left behind. I think that's very important. Just a short-term study showing that it works is, I don't think, adequate evidence to translate it to patient care.
Great point.
You know, like she said, like in the presentation, that she's now trying like larger defects. Maybe she's also trying like amount, like longer follow-ups and things to say if this worked, because it up to now it seems like it's pretty much as useful as Gore-Tex, but yeah, we have to see it.